Hello. So, good evening all. So, I'm just speaking about anterior segment OCT, how it can be used as a third eye to diagnose in our corneal disorders as a comprehensive ophthalmologist, how we can use it in our daily OPD. So, I would just go through few case examples so that how it aids we can just know. So there's an evolution of AIOCMTC4 from time domain to spectral domain to SWEP source, each of them having greater penetration, better angle-to-angle coverage and better depth. So the recent one is the SWEP source. Even a time domain would do good if you are having a tier 2 practice and all. So an AIOCMTC4 can give us so many things: line scan, corneal pachymetry, and corneal power adapter, epithelial thickness, everything. But I'll be just speaking on how we can use AIOCMTC4 as a line scan modality, how it can be used. So we'll just see how a normal cornea looks in your AIOCMTC4. First is the hyperreflective layer of the tear film, followed by the translucent layer of the epithelium. Then the hyperreflective layer is the Bowman's membrane, a varied reflectivity of the stroma, and then the last hyperreflective layer will be your Descemet's endothelium complex. So coming to the diagnosis of the ocular surface lesions. So this is a case of OSSN, where the lesion is spreading from conjunctiva to the limbus onto the cornea. So we can say AIOCMTC gives us an optical biopsy in this case, where we can see abrupt transition from the normal to abnormal epithelium, hyperreflectivity of the epithelium, and the underlying structures have been clearly demarcated. So a non-invasive method to just find out that this is an OSSN. Apart from this, when we gave a first cycle of 5FU, clinically the picture shows it is resolved, the lesion is no more there. But when we do an AIOCMTC, we found out that there was still a hyperreflective layer of an epithelium there. That normal translucency had still not come back. So another cycle of 5FU had to be given to get back the normal translucency of the epithelium. So we can use this as to monitor and diagnose. So we can use it in to assess the depth in order to plan certain surgical procedures. So when this is a case of a pigmented lesion near the temporal limbus, don't know whether it's a nevus or a melanoma. Just doing an AIOCMTC, we can just see there are some cysts with overlying shadow, which suggests that this is just a simple nevus, and you can go ahead with the planned procedure involving the site. In case of granular dystrophy, what are the layers at multiple layers or multiple depth the granules are present, we can decide. Upon that, the surgical procedure which we have to do. If it is in first 150 micron, we can go ahead and do PTK. If it's in a deeper layer, then we have to do some other procedures like DALC or PK, whatever. In case of extensive pannus dissection, in case of chemical injury, when we don't know what is the extent of pannus, we can't see the depth of the pannus. When we start dissecting, if it is involving only the superficial stroma, as in this case, we can just get away by doing an pannus dissection and AMG and BCL. If it's involving more than 2/3 of the stroma, and then we need to again go ahead with a different procedure. So assessment of different surgical methods can be done. And yeah, here this is a case of pseudophakic bullous keratopathy, where the underlying stroma is hazy and we can't see any iris details. And in this case, we would, as a textbook says or whatever, we would just go ahead and do optical keratoplasty, full thickness keratoplasty, better than a lamellar procedure. But then when you do an AIOCMTC, what you can see is the first hyperreflective layer is just a thickening of the epithelium. Underlying stroma, there is hardly any scar. So you can easily debride the epithelium, get the clarity of the underlying tissue, and go ahead and do your lamellar, like dissect can be easily done in this case. So in order to measure the outcome of the surgery, this is a case of post-dissect which came to us with primary graft failure, post-operative 1 month. On doing an AIOCMTC, what we found out was there was a reversal of the graft. So on doing the ASOCT post graft, post disc surgery, the proper orientation of the graft is very much important. As you see in the left side, where there is acute angle and the endothelium side is longer than the epithelium side. This is the proper orientation. In case of chemical injury, you can assess the epithelium loss, whether it is there or not, whether it is involving the stroma, and also to monitor the epithelium growth following the chemical injury. This is a case where post AMG BCL tarsorrhaphy was done. With BCL and tarsorrhaphy, we can't assess the epithelium in slit lamp. So you can just see the translucent part of the epithelium has come back and pannus has come back, so indicating no additional procedure of AMG or could be done in this case. So in case of Descemet membrane detachment, it is a very useful tool to classify it, to find the area of detachment, and also to find from which clock arm we have to insert the air bubble. So hazy cornea post cataract surgery, difficult to find out what is it behind. Then when you do an ASOCT, there was a undulating membrane which you can see here, and then that indicates there was a Descemet membrane detachment at 9 o'clock position. When you go ahead, take the patient in the OT and give an air tamponade opposite to it, that is at 3 o'clock, you can see the complete attachment of the Descemet membrane. In case of foreign body removal, first thing, we can just multiple foreign bodies, as in case in our places we get stone cutters and cement workers who come with multiple foreign bodies in eye. So you can just do ASOCT to assess the level of each foreign body. If it's superficial, remove it in slit lamp. If it's deep, not affecting the visual axis, just leave it. If it's even more deep, then you have to go into inside the OT and do it. Post foreign body removal, this case I thought I went deep. I found there was adequate stromal and posterior stroma and Descemet there, so I did not put a BCL. In this case, I went even more deeper, so there was a very thin strip left, so BCL and glue had to be put, or otherwise he would have come with perforation. So this is a case where there was through and through of foreign body, where anterior approach would be impossible. So this ASOCT told us it was through and through, so we had to go and remove it in the OT. This is just a last slide. So here the patient had gave me a history of bee sting, wherein manually he removed the insect had stuck into his eyes and he had to remove it. And after that, he had a corneal ulcer. He went to multiple places where the ulcer was treated. He came back to us with this picture, steamy cornea with ulcer. We don't know the remnant of foreign body yet. And doing an ASOCT here, we could find there was a sting. The foreign body was still present. So we had to take inside the OT, remove the foreign body, and then continue the treatment of the ulcer, and it was treated. So I would say ASOCT gives us a third eye in addition to the slit lamp microscope what we use in regular diagnosis near anterior segment. Thank you.
Thank you very much, Dr. Deepti. I just got one question. Usually our gastro friends send cases for us to look for KF ring. Does ASOCT help in KF ring? I remember reading an article that there are certain changes
in the time domain, maybe in the higher end, maybe the swep source or whatever, that SD we can use, but I generally use this Topcon, which is
Topcon is good, yeah.
Yeah, I have not found, sir. In slit lamp only we can find that ring.
Sometimes there will be a doubt. Sometimes they'll have some pigmentation. There will be a doubt it is KF ring or not.
Not, okay.
Does ASOCT help?
I have not tried, so maybe I'll keep this in mind.
Keep it in mind and look for the articles.
Yes,
I think I remember reading some article on that.
Yes, I'll do that. Yes. Thank you.
Thank you very much. Next.
I think, who's the next one? So, yeah, thank you, Deepti. That was a very good talk, and you've shown all the practical aspects of usage of OCT anterior segment. So, we have Dr. Vishwajyoti. Kunal. So, the last one. Okay, so I can actually go next. I am Harpreet.
You can.
If you want, you can go ahead. Just go ahead. Okay,
ahead,
since you are there.
You can go ahead.
Yeah.
Wills is there. Vishwajyoti is not there.
I don't know.
And Shakeen Singh is somewhere else. Next you and next me.
And I don't know about that girl there.
This one is not working. Yeah. So I will be talking on smart hospitals. My name is Kunal Agarwal. So I'm running an IT company called Easy Solution, and we are dealing in hospital management system. So when we talk about the smart, so what things? Next slide, नहीं हो रही यार. Next. Move नहीं हो रहा. Yes. Yeah. So when we talk about smart, so we have talked about smartphones, smart cities, smart people, but never spoken about the smart hospitals. So what we mean by the smart hospitals? Smart hospitals are basically giving a better patient experience, better profitability to the hospitals, better people and process management. So I will be talking about the 6 C's of smart ophthalmic hospital. So one of them will be the convenience, communication, continuous quality improvement, customization, care, and cost. So when we talk about the convenience, so here are some example of the convenience, how we can provide the convenience to our patients. So one of them is like 24/7 appointment booking, because the patient can want to have an appointment at 1 a.m. in the evening or whatever. So we can provide them an online tool where they can book a live appointment, pay online, and come into the center and straight away go to the consultation. They need not to visit the reception or something. They can just go, and like we do a check-in at the airport, we can do the similar check-in at the hospital. And similarly, then we can also provide a smart reception and queue management system. And those days are gone where the queue management and the queues are displayed on the television screen. Nowadays, people can see the queues on their mobile device. So they can visit the cafeteria, they can sit in the cafeteria and view when their turn is about to come. So this is the definition of actual being smart, where we are providing that kind of convenience to the patient and not making them bounded to a particular waiting areas or something like that. When we talk about the communication, so communication is very important tool for any hospital. We need to send the automated reminders, whether it's related to the appointment, whether it's related to any camps we are conducting, whether it's related to post-op follow-ups or any other thing. The systems which you should have that kind of capability to send you the reminders. Also the educational tools. So the patient engagement is very important nowadays. So in the patient engagement, systems are capable of an AI tool where the systems can automatically understand the diagnosis of the patients and send the related videos, related content to the patients. Patients always feel connected to the hospital when they receive such kind of content. And after that, we can also provide the transparent billing and treatment plans. So these are the tools which we can use to provide a better communication to the patients. When we go to the next C, that is continuous quality improvement. So all of us, we have to go with the NABH. So systems nowadays are so much capable of helping you out in the NABH assessment and reassessments. So systems are capable of giving you the OT checklist, turnaround time reporting, clinical audit reports, infection control logs, medication safety reports, and other things as well. And system also can provide you the real-time dashboards of understanding what is happening on the flow, and also the instant patient feedback loop integrated into HMIS with actionable analytics. Then we go to the next C, that is customization, where we come to the patient profiling. So EMR can capture lifestyle, profession, and affordability of an IOL package, and in the counseling we can suggest the patient according to that. Tailored communication, premium IOL options to the corporate versus affordability plan for the other patients. Customized care pathways, up schedules based on diagnosis, glaucoma versus cataract. When we go to the next C, that is care. So EMRs nowadays also help in clinical decision support system. So when you're prescribing something, system can help you out in avoiding any kind of human error. Suppose a patient is sulfur allergic and system can, you're prescribing some medicines which should not be prescribed, system can give you an alert. And it can also help you in IL power calculation, glaucoma risk alert, diabetic retinopathy reminders, and other things. Then we have the seamless journeys, pre-op counseling, intra-op details, post-op follow-up, all recorded. Then we have the safety protocols. So safety protocols can also be taken care by the hospital management systems. Then we go to the cost. So in the cost, systems are capable of optimizing the cost, making your process more efficient and optimized. So we can have the optimized resource uses using the OT scheduling, staff allocations, tracking the lens inventory. We have seen that in many hospitals, the lens inventories are not managed properly. There is a lot of damages, theft in the inventories that can be prevented through a good hospital management systems. And then error reductions through the no duplication of tests, fewer manual billing mistakes, and all other things. And then financial transparency. So the financial transparency can also be managed through the hospital management systems. So HMS always empowers the ophthalmologist and the hospitals to provide a better care, optimize their operations, and give a better outcome. So this is about us. We are 23 years into this hospital management systems and managing 1 lakh plus transaction. So this is again me, Kunal. Thank you.
So, Mr. Kunal, yeah, so this is you store all the data in the cloud or in the hospital
We
servers?
give both the options to the hospital. If they want to have the on-premises, so we give the on-premises one. If they want to have the cloud, so we do both the ways.
So, if it is on premises in the server, do we buy the software from you for the lifetime, or
Yeah,
is
the
it
licenses are generally perpetual, like it's for the lifetime. Then you have to obviously take some maintenance for the longer run and longer support, that
so
kind of thing.
how costly is that?
It all depends on the scale of the hospital.
For
So small,
for
for the
example,
smaller hospital is
10 computers in a hospital.
for a 10 computer. See, generally in IT industry, for a good software system, the AMC revolves around 15% or 20% of the project cost. That is an yearly
15% of the actual cost of the software.
of the software. So that is generally if the company is providing you good support, then they will charge this much of an amount.
So this support will be online or on site?
See, generally 99% of the IT things can be sorted online, but if it is required on site, so that can also be possible. That can also be made possible. So in a practical scenario, we do send people on site for any kind of troubleshooting or support. Even when the customers are satisfied with our services, then basically they even don't want the people to come. They know that the things can be done online, but even real circumstances, they want the persons to visit, so the people are there to visit.
Do you want an in-house a person who is really good in computers, like
I
an
don't
IT
think so.
person?
No. We don't require. We require a person who know bit about the IT and more about the hospital, and who can be a key user, who can train other users as well and motivate them to use the HMS. The major problem with using an HMS is like the adaptability and how much percentage of HMS you are using, because you can buy a very good system, but you have to utilize it. If you are not utilizing it, then it's a waste of efforts. So that is the thing, because HMS is nowadays more than EMR or billing. Nowadays it's a data science. So how you're pulling out the data, how you're evaluating your processes, how you're optimizing by using those kind of MIS reports. So that is very important. So nowadays we also have the leadership dashboards. So that on the real time basis you can see what is happening actually on the flow, and where we are lacking, from where we are getting the patient, and which are the area where the patient flow is reducing. So these are some examples where these corporate hospitals, why they are having an edge, because they are analyzing all the KPIs. So now these systems are capable enough of giving you all the statistics based on the KPIs and also comparing it with the market standards. Like if you're talking about the conversions, so what is the market standard for the, if a patient has been advised a cataract, so your conversion percentage is somewhere around 8 to 10%. So what is the standard of the market? Suppose the market standard is 12%. So you are below the market standard. So you have to improve. So these are some examples where you can improve.
Thank you.
Thank you.
I just had a question. This is, yeah. So, is your software customizable? Is there an option for, say, like, a particular hospital wants to introduce some extra, things like, for example, you might be having a standard of, how you kind of incorporate the various options there, like, say, visual acuity. So if somebody wants to introduce that, do you have the option? are you flexible enough?
Yeah, so basically we divide that thing into two parts. One is a configurable. So nowadays system is so much configurable that 90% of your customization requirement can be sufficed with that. And even after that, we feel that there is certain requirement which require a customization of the product. So we are always open for that.
And when you have it on site, as I was saying, so when you provide the unit on site, so no data goes to your server
No,
then,
no,
in
no,
that
no,
case.
no.
So
Even
data protection from that point of
absolutely,
view,
absolutely.
then I think hospitals, do they prefer the, the on-site
See, it all
installment?
depends. If they don't want any kind of headache of maintaining the IT, so they go for the cloud. But even on the cloud, we have a dedicated deployment. So when we talk about the dedicated deployment, there is a default NDA in place, non-disclosure agreement. So it's impossible to data to be leaked out. You can see that bigger enterprises are on AWS, Azure, and their data is pretty much secure because they have an NDA in place. So I think that. So we also had the IT audits with some.
Yeah.
So the last part of the answer is that we also had the IT audits with some bigger corporate chain. So there these questions also arise, like how we are preventing the data theft and all other things. So the system came all clear.
Yeah.
Okay.
Thank you.
Thank you
Thank
so
you.
much.
So the next talk will be by Dr. Harpreet Kaur Kapoor, ensuring safety in cataract surgery, optimizing sterilization protocols in the OR.
Thank you. So can we switch that off? Right, this mic, this speaker.
It's coming to the speaker.
This is the other hall. Yeah, because इसको बंद कर सकते हैं आप, कोई उनकी आवाज हमें नहीं चाहिए ना साइड रूम वाले की, डायरेक्टली आ रही है. अच्छा, I thought वो speakers. Okay, okay, that's fine, we can't help it. Thank you so much. Of us are here. So, yeah, but yeah, we have this duty of completing our task. So, I will be taking you through some of the, safety measures which we need to have in place to ensure that we have a safe surgery undergoing in our hospital. And of course, and the focus will be on sterilization protocols in the OR. So, as we all know, infectious endophthalmitis is one of the most dreaded complications for all of us ophthalmologists. And although current day cataract surgery is considered to be pretty safe, but yet again, it has been seen that worldwide, of course, the incidence is just about 0.04 to 0.2%, but studies in India have shown reported to be around 0.08 to 0.16%. And if we see, like, say, a presumed sporadic endophthalmitis case, in those patients, mainly the causative organism is gram-positive cocci. They are the ones which are the culprits. And usually in those cases, it's the patient-related factors. However, cluster endophthalmitis, which can be an ophthalmologist's nightmare, those are usually caused by gram-negative organisms or usually fungal. And here it is the surgical environment which is to be blamed. So, although the focus would be on the environment as such, but very quickly I'll just take you through some of the key pre-operative measures which shouldn't be overlooked at all. So, blood sugars, of course, should be done within 1 week of surgery. Fasting have a maximum as in it should be less than 140. Don't go beyond that. PPBS, RBS, max less than 200. And then I think some centers, of course, would have a physician assessing the patient, but then if you don't have that, sometimes it sounds very simple, but just a simple history of skin lesions, any abscess, because that all patient might not be might not think it's important to share that, but yet again it can be catastrophic in some cases. So abscess, fever, UTI, URI, have a urine routine, regular examination done. Lids and adnexal infections, if you have, treat them first and then go in for surgery. And then contact procedures like biometry, tonometry should be avoided on the day of surgery. Povidone iodine is a must. And pre-op antibiotics, 24 to 48 hours, sometimes that's the routine. But in literature, it is the povidone iodine which has a definite role, and it has been kind of, shown to decrease the incidence, majorly minimize the incidence. Okay, coming to the surgical environment. So in one of these meta-analysis, it was seen that out of the sources of infection, it was operating room environment, surgical instruments, contaminated intraocular solutions, which were the key ones. So it could be the trypan glue, the viscoelastics which you are using, and then also the phago tubing and handpiece. Sometimes even the contaminated topical anesthetic eye drop. Some places I've seen, the eye drop is just kept there in the OT. No, dates are not mentioned. And also, you might just be using a contaminated eye drop into the patient's eye and just going ahead with surgery and landing with a problem just with a simple eye drop. And IULs, of course. Okay, I'll just start with the OT complex layout. So, as we all know, it should be scientifically planned with adequate barriers. We all might not have, a very fancy OT, but just the same, having protocols in place and ensuring that the staff kind of rigorously follows these protocols and barriers are maintained between the outer zone, clean zone, aseptic zone, and disposal zone will help you save yourself from a lot of issues there. As far as the operating room is concerned, the wall should be impervious. Central air conditioning is preferred. And if you don't have access, then split AC instead of window ACs. Window ACs are a no-no, and so are fans. We've seen some places fans are also being used. And then vertical laminar flow is great to have. HEPA filter should be installed. So this is an ideal situation I'm talking about. And temperatures, of course, if you have an air handling unit, temperatures between 18 to 23 degrees, and humidity should be between 30 to 50%. So then coming to the fumigation, the OR as such, how do we sterilize that? Use standard solutions, bacillocid. So I mean, sometimes people try and save money on this particular aspect. I think this piece is very important. You'd rather save elsewhere, but do invest in such important things like say the solution which you are using for fumigating the OT. It's good to have nowadays the fogging machines which are available. Just have a time of about 30 minutes to 60 minutes, so that's good to use these. And then besides the OT sterilization, it's important to have microbiological surveillance also. At least once in a month, it should be done. Sometimes 3 weeks is good. And yeah, going to the surgical instruments then. Of course, standardized or sterilization protocol should be in place. You use the autoclave, ETO machines, and then besides having standardized autoclaving and processes in place, it is important to monitor the sterilization as well. Use chemical indicators. It has to be used inside the tray, outside the wrap, and then the external wrap as well. And then record keeping is absolutely essential. And just today, I was shocked to, I was having a chat with a head of a medical college, a renowned medical college, let me tell you. And that person, when she moved there, she shared that boiling was still going on. And it was, a medical college of recent repute, decent repute. Yeah. And then she said I had to really put my foot down to, just stop that. And they were thinking, why now? Anyways, so aseptic protocols for OT personnel are equally important. You can have best of OTs, but if OT personnel are not following diligently the protocols which are in place, and so, for example, I've just put up this picture, which is the wrong way of scrubbing. Mask is beneath the nose, hands are down there, and then the religious thread there, the ring there, not going to save you from infections. So, yeah, so have training, retraining for your OT staff so that appropriate scrubbing techniques are used, and gloving, gowning, all of these have standard, protocols, how they should be kind of done in a proper way. I'll just take another two because we don't
Yeah, yeah,
have,
go
so I
ahead.
guess I can,
Go ahead.
that's why I was relaxed and going
I
ahead.
got a lot of questions also for you.
Yeah, okay, sure, sure. I'll save some time for that as well. So, and then, yeah, this you all know. So, intraocular solutions, of course. So, it's good, like in high volume centers, it's good to have a microbiological workup of each batch. And then, when you use the solution, do a physical inspection first without shaking, and then after shaking also, because if you find some particles there, preserve the bottles of irrigating solution for 24 hours and note batch numbers of all consumables. Having said that, it is very important to document. So while you are all there to save your patient's eyes and have a good surgical outcome, it is also important to save yourself. So very important to document. Thank you for your patience listening.
Thank you, Dr. Harpreet Kaur Kapoor. A lot of questions for you.
Yeah, sure. We
You
have all
said
the time.
we need to avoid contact procedure just before the surgery. But now the toric marking has come up, so we just need to do the toric marking 0 and 180 degrees in all the patients where we, unless you have things like Varion, we still sometimes, even if I have the Varion, I still would like to have the 0 and 180 mark, because sometimes the Varion doesn't really give that 0 and 180. Sometimes it goes off. If you are sitting a little away, it goes off. And only when we have the 0, 180, we can again reposition ourselves and then correct that also.
Yeah, your very well point is well taken, and a good question there. So I use the bubble marker, which is ETO'd. So
Okay.
when you use the toric marker, make sure that it is sterilized. But let me also say, the bubble marker should not go in the autoclave. I
the bubble
very
goes off.
recently had an incident where the staff put it in the autoclave and it's gone. So yeah, it should be ETO'd. Yeah.
ETO.
So use sterilized marker.
Next question. Your blood sugars less than 140 fasting and less than 200 postprandial or RBS. Yeah, this is the standards that are given by the AIOS protocols. Nowadays, the fashion is to get the HbA1c done. Patients don't get the blood sugars done; they get the HbA1c done. Is there any standardization for that now?
I don't think that is relevant actually. See, HbA1c tells us about the last 2 months or so.
3 months.
So
yeah.
even if 2 to 3 months, if it's controlled, but say within the last week it is not controlled, that doesn't make sense.
Yeah.
Because for us it is important that during that period, like say when we are doing the surgery, and in fact some people they say we are controlling our diet and having our blood sugars controlled. So I say just give me these 3 weeks. Start on medication, 3-4 weeks you take your medication. After that you keep doing whatever you want to, for all I care. I mean, not really, but just the same, the point is that during that time the blood sugar should be controlled. So HbA1c I believe is really not a good
helpful for us. Yeah.
No.
I tell my patients, like, it is not for my sake, for me to do the surgery that you're controlling your sugar, but it's for your wound
Exactly.
healing for the whole month and the rest of the life, for you to that your sugar should be controlled, and I motivate them.
Yes.
Other thing, scrubbing. We use time tested. We boil the water, use a kettle, and nowadays we are using the reverse osmosis. For example, simple Kent is installed near the scrub area, and then directly from that we scrub our hands. How do we sterilize these taps?
Oh, well, yeah, that is one area, of course.
Yes.
But then,
how do we sterilize the taps?
yeah. So, I mean, see, one thing is what we can do, what's in our control is that we can use we should be using standardized solutions like chlorhexidine and betadine. So don't use soaps and all soap. I mean, sometimes I've seen some people using that as well. So if you're using that, and then, yeah, so if you have to sterilize, if you have to go that way, then probably what I would suggest is when it's dry in the morning, one person cleans it up with the ethyl alcohol.
Yeah.
So go inside, just, maybe just a squirt.
Fine.
Yeah.
The outlet is clean.
Exactly.
What about from the Kent to the tap? This tube, how do you sterilize this tube?
So like I said, we just have to monitor, and this is not under our control. So there are certain things which aren't, But as a, I think I would say, like, just a double protection. Once you've done the scrubbing, the way you do your gloving, that's important. So that is the time when you don't touch your hands.
Yeah.
Even if there's some level of infection still persistent because of that tubing and whatever the
You
water
have a barrier
source.
of the glove.
So it's, yeah, there is a technique of wearing gloves also, like you have put your hand in. So your skin should not touch the outer aspect of the glove, which kind of goes in contact with the. So we can discuss the whole day actually,
I know.
because I am really deep. I am very passionate about this aspect. And in fact, like for example, for staff, you simple things like when they give you the instruments, don't touch the tip of the instrument. That needs to be told, because sometimes, say in a general hospital setting, in surgery and all, they usually hold hold it. If you remember your MBBS days, they hold the tip and give it to the surgeon. So this shouldn't be done. So for our staff, we have to tell them hold the back end, so that everything, whatever goes in, anything which goes in the eye should not be touched.
Yes.
And,
Yeah,
and
that's the
sometimes
standard.
even like when I was talking about, you said gloving, we jumped to gloving. Before that also, there's one aspect when you're cleaning your hands wiping your hands with a towel. So there's a technique for that also. But sometimes, quite a few times,
Yeah.
they'll come your hands like, like you are washing in a washroom or something, but then there's a certain
No,
technique.
they wear the gown like this.
Yeah. So
You are touching the.
yeah, so these aspects also. So once, like in case there is some infection, I would say all we can do, because there are certain things which are beyond our control. So this proper technique of gloving, gowning, wiping your hands for that matter, will help you save yourself. Yeah.
Thank you very much.
Okay. Thank you. Thanks.
Next, I'll be talking on effective communication and efficient practice in ophthalmology. Good evening, everybody. Let's wrap up the session with my talk. I'm Dr. Rajesh Ganesan, and I thank AIOS for giving me this opportunity to talk on effective communication in ophthalmology. And I really thank the Punjab Ophthalmological Society for arranging such a good venue and a good conference. I acknowledge with thanks to Dr. Indu Arneja, the Director of Indian Institute of Healthcare Communication, from whom I took a lot of inputs to make this talk. So the question now is, why communication? There's a lot of demand from the patients who wants to know more about their disease. They want to be explained, they want to be given all the facts, whether they understand it or not, but they still want to know all the facts, and they want to participate in the patient care. They want to take the decision. And we have to introspect ourselves. Am I communicating enough? Am I talking the right thing to my patients? Am I communicating well with my staff? Am I communicating well with the referring doctor? And am I communicating well with the other consultants and the staff in the hospital? So the good news is that communication can be easily learned, it can be easily acquired, and we can easily modify it according to the type of the patient that we receive and the type of the patient that we would like to deal with. According to the Indian Institute of Healthcare Communication, there's an institute like that which deals with this. The good orator does not mean that you are communicating well. The right words that we say is only about 7% of the communication. The rest of the 93% of the communication is the tone of the voice. That's almost about 38% of the communication. And the body language. You have an indifferent body language, and it doesn't really, that measure doesn't really sink into any of the people that who are really listening to you. If, to that matter, not listening to you, even though you are trying to put up your point, if your body language is not correct, nothing goes into their heads. It doesn't go. So when you're talking to your patients, don't keep looking at your phone. Don't engage yourself from anything else other than giving attention to your phone. Don't have even your sitting posture. If you're sitting in a indifferent way, that doesn't really sync with your with the patients. Even they don't like it. They feel that you're not giving them enough attention. So you should always have a positive attitude. Don't feel that the patient is a burden to you. Arey yaar, abhi aa gaya. No, There are so many people, so many doctors, so many consultants who are waiting for a patient to come. You have a patient in your hand. You should be very happy with that. You should be very happy that you are attending to the patient and the patient has chosen you. Be happy with that. Don't be अरे अभी आ गया यार अरे अभी मैं जा रहा हूँ कल आने दो कल का आने के बोलो. No, don't do that. Attend to them. Be happy. Show your happiness by your attitude towards the patient and demonstrate your willingness to engage in the conversation. Greet them properly, call them by their name, make eye contact, smile, and most important thing, listen attentively. You have to maintain an open posture, lean forward, like it's like showing attention. Pay attention by nodding and smiling appropriately, not smiling to your phone. You smile, you give an appropriate smile to your patient. Use appropriate tone. Don't use a rude voice nor a harsh or intimidating voice. Use the right words with the right tone, which is very important. You should allow your patients to express if the conversation, and sometimes your patients will be talking about their granddaughter, about their, okay, let them do it to a certain extent. Give them a little 1 minute time for that, or maybe 1.5 minute time for that. Then if the conversation is going too far away from the disease, slowly bring them back. You can bring them back. And accept emotional reactions without being too emotional yourself, too reactive yourself. You don't start crying with your patient. Yes, but you have to show empathy to their problems, but you don't be overreactive to that, and be comforting to the patient and the family. Assure them. Show empathy, as I told you, show honest behavior that you understand how painful the patient is feeling. Be honest about that, and then you'll be able to take a good decision and treat your patient properly. Patient sees your communication skills more than your clinical skills. That's why many of the whom we call quacks are more successful than many of the very well qualified, highly super specialist doctors. Yes, because of their communication skills, answer to their questions properly and clarify their doubts completely. We as ophthalmologists deal mostly with the elderly patients, and these elderly patients, we have to listen to them and allow them to speak. Don't cut them off, allow them to speak, make them comfortable first. Only if you allow them to speak, they will be comfortable, and you can win their confidence. You have to listen to their problems, let them open up to you with the information and develop a rapport with them. Only then you can get the full information from these elderly patients. So when explaining about their illnesses, make yourself available first to explain about it, and tell them why did they get it, what can be done about it, what options are available for the treatment of that condition. Let them participate in the decision making. Give them the chance to choose the treatment modalities. The 1, 2, 3, 4 modalities are there. Give them the chance and give them the choice of admission of the daycare. If they are from far away, okay, tell them, okay, yeah. Stay for a night and tomorrow you can get it done. Or if they are daycare, okay, get it done and go back home. You can come back later for a checkup. You can customize that. Involve the patient's family in decision making. Provide them all the information. Facilitates in the decision making. Lead them to the appropriate, safe, good decision. It is your skill to lead them to what you want to do, and be honest about that. Let them select what they want. Don't force anything. Ultimately, when they develop the confidence, they will put the ball into your court, and they will tell you to decide for them. So better communication helps in diagnostic and treatment accuracy. It helps in patient compliance. It helps if the patient understands the disease properly, we can do the proper investigation, and they can follow the treatment protocols properly, and whatever surgery is required, they will get it done because they get the confidence about you. Communication helps in the patient's safety, right from the security, the parking attendant, the receptionist, the refractionist, the helpers, pharmacists, billing, different departments and different teams. When they communicate properly, only then it reduces the medical errors. Otherwise, if you don't have communication between all these departments, it will be chaos in your hospital. Usually, most of the time, the patient unhappiness starts at the parking. Can continue that. Starts at the parking lot where the parking attendant is very rude to them, and then that ends up as a fight in your chamber. So all the departments should be synchronized, and then they should all be aware about this. Display respect and patient care at every step in your hospital. Make sure that everybody in the hospital takes care of the patients, and this reduces the medical good communication between the nurses, doctors, residents, patients, and the patient's family. Errors can be avoided. That reduces the day-to-day chaos in your hospital working. So better communication helps to reduce the conflict between the patients and with the patients and their families. It helps to reduce the medical negligence allegation, because they believe in your word and gain greater patient satisfaction. It's also very important to communicate well with your team. You have to appreciate your team. If somebody is doing good, appreciate them. Somebody is doing bad, somebody is not following your protocols, don't shout at them in front of everybody. Call them to your chamber, make them understand how important it is. So instead of shouting at them in front of everybody, make them understand. If they don't follow your hospital protocols, it's up to you to call to keep him or send him away. You should always acknowledge their input. Even your parking attendant, if your parking attendant is very indifferent, sitting there just not doing anything, somebody comes to park a car, he will just say, you go there. Instead of that, if your parking attendant also says, "Arey, good evening sir, aa gaye aap," that brings so much of confidence to the patient. So it starts right from the parking attendant till your chamber in your to you. Yes, everybody. Not only the reception is the third stage. The parking attendant, the lift attendant, everybody is. So many people are there before they come to your reception. So everybody in the hospital should be aware about smiling and communicating properly to you. So this gives more personal and professional satisfaction with better name, fame, and many footfalls to us. And one more thing is time management. Don't ever ask your patient who is 100 kilometers away to come again tomorrow, or to come again after 2 days. My God, he has to travel 100 kilometers away and come back again after 2 days. Is very difficult for them. You should titrate. You should titrate. He's from nearby. Okay, tomorrow I want to see you again. He's from 100 kilometers away. Give him a 10 days time. Make sure that your treatment protocols, or admit him for 2 days and then do it. So don't send him away just like that. Value the patient time. It's very important for us to value their time and give them proper appointments. So, and it's very important when we are referring our patient to communicate effectively. Tell the patient why you're sending them to the other institute and document it. And communicating with the patient who has come for a second opinion is also very, very important. He has already rejected your other doctor and he has come to you. You don't have to talk adverse about the other doctor. You don't have to do that. He has already rejected him and come to you. You can say, "Arey yaar, ab tak jo hua, it's going in the right time, in the right direction. Now let us change a little and then see how it works." That is the way we have to respect our colleagues also. There's nothing you will gain by saying bad about or saying adverse about your colleagues. Second opinion is nothing wrong. If somebody is, you're not if you're not able to get a solution to the patient, you can always say, "Shall we take a second opinion? I have a friend who works who sees more of these cases than me. Let us take a second opinion." That is the way. The patient will definitely come back to you. He'll definitely come back to you. "Sir, आपने अच्छे जगह से भेजा आपने. I've gone there. I've found a solution. Now I'm fine." He'll bring his other patients. If he'll specifically say, if this doctor does not know how to do, he will know where to get the solution. So he'll bring you more patients to you. That is one thing I've personally felt it. So finally, good practices tips: build rapport with your patient, practice transparency, address the patient's concern, practice informed decision making, give realistic expectations, accept professional limitations, keep the patient and the family updated, communicate what you document and document what you communicate, and learn to control your emotional reactions. Thank you very much.
Thank you so much. Thanks. That was very interesting. And I think you covered some very important aspects which are generally missed. And yeah, so I think one thing I just wanted to share at this point. Somebody, one of my teachers, I remember, used to say, you've said address the patient's concern, but sometimes, what happens, patient comes to you with watering or itching, redness. So that for the patient, that part is important. So sometimes it happens, कुछ नहीं है, no, नहीं है, आपको कुछ नहीं है. That then with that the patient keeps going from one doctor to the other. So it's
See.
important to listen and address that person's concern.
Why should the patient take time? It may take 3-4 hours for him to from his house to your hospital, spend money on your consultation. Why should he come to you? He can, if he is fine, if he has no problem, he will be in a mall or in a cinema theater. He has spent time and money to come to you, means he has a problem which, if you say kuch nahi hai, you are not able to identify it. Kuch to hai. We should look into it. Yeah. Otherwise, why is he coming? Why is he wasting time and coming to you and giving money to you? There is something we are missing. So, I'm not able to. You don't have to admit that you are not able to identify anything. You can just give him, use this. Let me see you again after a week.
Yeah, it's important.
So, if you can't find something today, maybe 1 week down the line or 10 days down the line, the same patient, you will be able to identify certain things. So you can always ask the patient to come back and then recheck him again. Sometimes the initial medication that you give, he'll be very happy and he say, bye-bye. He's fine. So his problem is solved. If it is not solved, you will have a chance to recheck your patient again.
Yeah, right.
So every patient who walks into your clinic has a problem. He doesn't come to your clinic without a problem. He has a problem. We have to find it, look into it, communicate it.
Yeah, thank you. Thank you so much. So, we don't have Vishwajyoti Behel and Meghna Roy? No? Okay. You are not part of this. Okay, great. Okay, then I think then we are
can
done
wrap
with
it
the
up, wrap it
session
up.
then. Thank you so much. Thank you to all of us. Yeah. Okay then. Yeah, we can take a picture.